Well, welcome to Unapologetically Queer. I'm the host, Al Ferguson, and I'm proud to talk to some of the most interesting people that are interesting to our LGBTQ plus community. At Hotspots Happening Out, our mission is based on the 10 pillars of the LGBTQ plus community. And one of these 10 pillars is information and education on AIDS, HIV, healthcare. AIDS in the 90s, HIV today, are perhaps the most important single topic in the modern history of the queer community. The World Health Organization and the U.S. government have set a goal of 0 new HIV infections by 2030. Is that even possible? Well, the answer is not that simple. MSM, men who have sex with men, are by far the most at risk for new HIV infections. Worse, 1 in 6 are unaware of their status. Especially difficult is how new HIV infections affect people of color in our queer community. Here are the facts. From 2010 to 2020, MSM new HIV infections in America stayed flat, stable. But among Black American men, 25 to 34, new HIV infections increased a dramatic 65%. Even worse, among Hispanic Latino American men, increasing 68%. If you are a white male having sex with men, there was virtually no increase. It was flat. Let's look at this crisis in a different way. The Black community represents approximately 14% of the American population. The Latino community, approximately 19%. But for every one white M2M new case of HIV, remember white is approximately 65% of the U.S. population, there were 3 Black and Latino M2M new HIV cases. 1 to 3. It's staggering. Today we're going to talk about health and HIV among Black M2M, and for this we are joined by Ederick Johnson and Dr. LaRon Nelson. Ederick is a noted minister of music and an HIV and LGBTQIA advocate, currently working with the Broward County, Florida Department of Health. He is here to speak on his work for MSM coordinator and also to talk about his new role at Yale University's School of Nursing. Also joining us is Dr. LaRon Nelson. He is the Independence Foundation Professor and Associate Dean of Global Affairs and Planetary Health at the Yale School of Nursing. He also serves as the Director of Justice, Community Capacity and Equity Core in the Yale Center for Interdisciplinary Research on AIDS. And Dr. Nelson is here to spread awareness about the work done through the HIV Prevention Trials Network, which focuses on improving HIV outcomes for Black MSM in the U.S. South. He hopes to get to 0 among Black MSM in the American South, testing the efficacy of an integrated intervention strategy. So, Ederick Johnson and Dr. Nelson, I understand, first off, get it right off the bat, you're both unapologetically queer.
Yes.
Yeah, that's right.
Both of you, right? Well, welcome today. Let's talk about these staggering numbers that we just talked about. HIV new cases being so much dramatically higher in the Black queer community, the Latino queer community. What's causing it? Why is it happening?
Well, I can honestly say, especially in Broward County, when we look at those numbers and we look at the area code, the zip codes that these numbers are in, we first should ask ourselves, in that zip code, how many places that an individual can go to receive testing, to receive outreach, to receive some type of education as it pertains to HIV, STDs, and STIs. The problem is that resources are not in those communities. 33311, one of those, the nearest testing site is miles away. So you're talking about people who not only have inadequate healthcare access, but also those on day-to-day living, trying to survive, resources. So a lot of these individuals don't have transportation. A lot of these individuals don't have insurance. So in order to get a test, they have to go miles and miles away from their home, but we know that the issues are in that community, but yet there's no resources in that community to provide.
Dr. Nelson, are besides access in the neighborhoods and where Black community may be living, or Latino community may be living, are there other factors that are contributing to the escalation numbers being so much higher in the Black and Latino community?
Thank you. A big problem is the social conditions haven't changed over many years, especially since we've seen the introduction of HIV self-testing, rapid testing, PrEP, treatment as prevention. Those have caused some decreases in HIV incidence, like you mentioned, among white queer men, but the social conditions have not changed for Black and Latino queer men, so that the benefits of these new prevention products just have not accrued to those communities. One thing that happens is stigma in healthcare facilities. So it's one thing to have multiple places that you could potentially go, but the climate, like what it's like in the environment when you try to go there to seek care, has an impact on whether or not you listen, whether or not you plan to go back, or whether or not you follow through with the prevention plans. And so we know that stigma is a big problem that is contributing to these disparities that we see.
You've come in today from Connecticut, from Yale, and it's a unique partnership between Broward County's Florida Department of Health, Yale University's South Florida office, and you both have partnered with the White House's initiative to end the HIV epidemic. Talk a little bit about what the White House's goal is and what you're trying to accomplish.
So, since the last presidential administration, they've started this End the HIV Epidemic initiative, which identifies 40 priority counties in the United States where we know this is where the epidemic is raging. Broward County is one of those 40 counties. What it really is trying to do is surge resources into places where they know if we're gonna curb the epidemic in the United States, we have to curb it in these areas that are, for lack of a better word, hotspots. No pun intended.
I want to ask specifically about this, the White House's program identifying these 40 counties. I've repeatedly heard that South Florida is among the top in the nation of new HIV infection. Is that true?
That is true, yes.
It is true. And so therefore significantly contributed over proportionately by Black men and Latino men. That's correct?
That is correct.
Yeah. The White House initiative to end HIV, to specifically focus on the South Florida community because of its high new case trend reporting and because of minority representation between Black and Latino. How does the White House program, Florida Department of Health, and Yale's program come together to try to address that and those issues?
Well, the federal government has, through mostly the CDC, I believe, has spread resources across these 40 communities, most of which are in the South, not just in South Florida. But the epidemic is definitely in the South, and it's definitely among Black and Latino MSM. So they put resources mostly through health departments. I mean, that's been the way to which they tried to distribute resources to scale up different interventions or strategies that they think will help curb the epidemic. In Broward County, Broward Department of Public Health has been very useful in terms of welcoming Yale's expertise in scientific investigation. So what we're trying to do is understand what can we do, how can we leverage the assets that exist in Broward County and other counties to figure out how can we optimize these assets, PrEP, treatment as prevention, HIV testing, so that we can decrease that disparity that we see among racial groups within the LGBT community, particularly among men who have sex with men. So we bring the scientific lens to the public health programmatic perspective that health departments and communities across the South are already doing, and in this community is the Broward County Health Department.
Yeah, one of the things that you say, which to be honest with you, I wasn't aware of, the preponderance of these 40 counties are southern counties. Why is the region of the South versus the Northeast or the West? Why is the South so significantly higher in new case transmission?
I will say I will have to go piggyback what Dr. Nelson said. Stigma. Mm-hmm. Stigma. You're looking at the South. A lot of our southern communities are deep-rooted in Christian faith, and we already know that within Christian faith, HIV is not spoken upon because you can't speak on HIV without dealing with homophobia, transphobia, and a lot of people still think that HIV is still a gay man's disease. And anytime I encounter someone with that mindset, I always ask them, what HIV starts with. It starts with H. It means human. It doesn't say GIV, gay. It doesn't say TIV for transgender. It's HIV, meaning human, that if you have blood running in your body, you're prone to it. Mm-hmm. So it is the stigma that has been placed by media, by individuals, by people in office. Mm-hmm.
So, in other words, if you're a politician preaching in related ways homophobia, or you're in the pulpit as an evangelist preaching against homophobia, or preaching against the LGBTQ community, that trickles into the health equity in our community, is what I hear you saying.
Yes, because many of those sermons I've heard deal with, okay, you're a homosexual and you know the end result of homosexuality, you're gonna get AIDS, not HIV. You know, and I tell people there's a difference between AIDS and HIV. You can't just go straight to AIDS.
Yeah,
you know,
we'd have to get into a time machine basically to return to that labeling. Dr. Nelson, I want to ask you. I was reading something that caught my attention. You're a public health nurse and a family nurse practitioner, and you serve as the director of an organization called the Justice, Community, Capacity, and Equity Core at the Yale Center for Interdisciplinary Research on AIDS. Help us understand that office and what your mission is and what you do.
Thank you. The Center for Interdisciplinary Research on AIDS, is CIRA for short, is a center out of the Yale School of Public Health. It's led by Trace Kershaw. He's a professor in the School of Public Health. One of the cores, the units within that center, is called JUCY, which is what you described: justice, community, capacity, and equity. What we're trying to do is figure out ways to build capacity in communities to understand local indigenous ways to help address the epidemic. Scientists have ideas that we sort of think about and read about and research, but people have been finding ways to survive for a long time without ever having talked to a PhD, right? Scientists, they figure out ways to do it. So what we're trying to do is figure out how we can leverage this expertise that already exists in communities and find ways that we can expand that so that we can increase equity in HIV outcomes. And that is mostly around building capacity in local communities.
Something else I wanted to ask you about is I was reading about this program called HPTN-096. I hope I got that right, and you'll correct me if I didn't. The HIV Prevention Trials Network. Tell me about that and what's its goal? What does it do?
So HPTN is a worldwide global network of scientists whose focus really is finding ways to end the HIV epidemic through prevention. It has been responsible for some of the main discoveries that we know about. So the treatment as prevention, this idea of undetectable and being untransmittable, that is a discovery of HPTN-052. And this, as we know, the long-acting injectable cabotegravir that is now being marketed was also a study of HPTN as HPTN-083. For example. So the goal is to figure out how can we be on the forefront of discovering what's going to figure out ways to end the epidemic across the world, not just in the US, not just in the South, but globally. HPTN-096, the study that you mentioned, is a specific study that's trying to figure out what do we need to do to optimize these products, these innovations that already exist, but are not helping Black men. What I just mentioned, treatment as prevention, oral PrEP, injectable PrEP, self-testing, all that has been available for a while. Long-acting injectable is relatively newer, but none of those things have changed the trajectory of HIV among Black men who have sex with men.
And again, that's because of access of the population neighborhoods in terms of the medical care, and whether a political or an evangelical homophobic kind of response to the Black and Latino community. Am I getting this right?
I think that's true. And even socially, even outside the clinic, the social environment. So think about it. To get access to PrEP, right, the physician or the nurse practitioner has to know certain things about you, which means you have to feel like you can say certain things about you in that encounter. And sometimes people don't feel like they can say it, or they can be real risk in saying it.
So I think a lot of people might be shocked at the words that they hear from the two of you, because the LGBTQ community faces, in the environment we're watching from our governor's mansion here in Florida, as one example, we face attack outside the community. But even inside the community, I, as a white, privileged gay man, have different access to HIV and prevention than in our own community for Black and Latino. That's what you're telling me.
Yes.
Well, that's complete inequity in our own LGBTQ community, and our community would be shocked of that.
There's even research that says providers are more likely to ask a white man if he has sex with men, and are less likely to ask a Black man, unless you present in certain ways, right? So,
No, you're right. And I will honestly say my time that I was with the health department before coming on to Yale, one of the things that I was tasked to do was academic detailing. So visiting doctors' offices and having these conversations with them to try to encourage them to not only be a part of the PrEP program, but also explain to them, when you encounter individuals, are we talking about sexual health history? Are we going through, when they come in for a checkup, if someone comes in and they were diagnosed with an STD, are you then going to give them options as it relates, okay, you have gonorrhea, you're what we call an at-risk patient. Have you ever heard of PrEP? Let's change the narrative. Have you heard about PrEP? Encouraging these individuals to get on PrEP, but as stated, doctors are more prone to ask a white same gender loving man these questions, but not Black.
The big picture of this, we reported on it, and we've reported extensively at Queer News Tonight, the World Health Organization's statement of zero new infection by 2030. What do you think about that? The commitment of having zero infection by 2030, is it realistic? Is it possible? Is it pie in the sky? Are we moving in the right direction? Where are we on that commitment?
It's ambitious. You can get there for some people. I think it's definitely doable for white men. I think it's possible. I think it is in the realm of possibility for Black and Latino men, but it's a harder goal to reach, because it's not just can you get the medication to people. The factors are multifaceted and they're multi-level. And unless we're willing to deal with the structural impediments, like, for example, you asked earlier about why is HIV in the South? Many of the states where the epidemic is raging are places that did not expand Medicaid. That has impacts for who has access to certain medical benefits, and that is racialized. And so if we don't deal with those policy issues, you can come up with new HIV devices all you want. The pattern is going to be the same. White people will benefit from it because they're in a social situation that will allow them to benefit from it. That same system restricts those benefits from accruing to other people. That's the only way we're going to get there. And we're trying to work with communities to see, can we build coalitions and find ways to do some policy interventions that might help us address those issues. But unless we do it, we're just talking. It won't happen.
That's kind of discouraging to my ears of what you've just said. I want to ask in just the broadest terms of understanding. We, through the medical opportunities that are available to us today, if they were universally embraced, we would wipe HIV out today, wouldn't we? We could prevent through PrEP, for example, or other kinds of situation. We would radically change HIV in America and the world. Do I have that right?
If you could scale it enough, you could stop the transmissions. If you had enough PrEP circulating in the community, and you had enough people on treatment, you could break the chain of transmission.
And it's easy access.
Yes.
Easy access to PrEP. Let's
Right.
Easy access to PrEP, because I know my frustration when I was on PrEP, frustration with insurance companies, the frustration with the doctor's office, frustration, going back and forth. Is the insurance going to cover it? It's a preventative medicine, but yet there's still arguments, within insurance companies, and you have states who are basically telling the insurance companies it's okay if you don't cover PrEP. It's okay. It's fine. But when you do that, look at the numbers.
Right.
And it just seems to me, in terms of my question to you and your answer, if we had a pill or we had an injectable that said, this will prevent pancreatic cancer, it would be universally embraced in America. And because HIV is so stigmatized based on it's a gay disease, that we are making different choices in so many different levels among so many different people. And the shocking thing here is even academically and medically, we're making different decisions.
And let me add, when I was working with the health department, one thing that caught my attention when I was working in COVID, for a year and a half, I was on the COVID task force. And when they got the vaccine for COVID, it amazed me at the line, because at that time I was working at Holiday Park when they did the vaccines. You talking about by 6 o'clock in the morning, the line was 3 miles away for a vaccine for COVID.
Yeah.
But yet we can barely get people to come and get on PrEP.
It's certainly a representation of the Puritan kind of thinking that we have in America, exported from an evangelical point of view. It's because this has to do with sex, we have a completely different attitude toward it. Yeah.
And I think related to what you asked which may also be uniquely American or more American, is the business lens. So this idea that we would universally give everybody access to PrEP just because it works is not something that really has been embraced by the business community. There's a bottom line that people are concerned about.
So it comes down to money.
It comes down to money.
Yeah.
So we have to figure that part out too.
To a gay community, we're all gay men here, to a community that has lost what we have watched lost fundamentally since 1982. It's just shocking to think that we reduce it down to the value of someone's life and the value of how they live their life. I'm curious, kind of closing thoughts. Both of you experts, you from Broward County, Florida Department of Health, you at Yale. Best thing that we're doing in HIV this year is what? What's the best thing that we're doing that's super successful?
I will have to say, because I haven't been at Yale long to speak on what is going on at Yale University, but as far as,
and I don't mean your own individual programs. I just mean across the board in HIV,
social
healthcare,
media.
And well, what does that mean?
Social media. When we did the MSM conference and we did segments within the conference and had social media influencers who has the followings to promote HIV messaging, because I believe in going where the people are at. Don't have them come to you. So we know that this population follows or listen to this person, and having these people come to the table and come on board and say, you know what, I'm going to join the bandwagon, and on my social media, because I have a platform, I am going to promote this. From Lil Nas, I think I pronounce it, is it Lil Nas? Yes. From that individual to local artists here in South Florida at Knick Knack London, who are taking the stand with their platform and speaking on HIV prevention and education. I think social media has helped us this year with getting message out to places where we're unable to reach.
Interesting. And from your seat and what you do at Yale in this work, what do you think is the best thing that you're seeing that's happening in the lens of HIV and healthcare in America?
To me, the best thing is that we are thinking about multi-level strategies to tackle this epidemic. I think before now, we've talked most about behavior. How do we get gay men to stop having so much sex with so many people and use condoms more? And the focus has just been on them, and it ignored the systems that predispose them to infection. And so now I think conversations are having that recognize it's not just the behavior of the individual. We have to figure out how we change the environment. So even our conversation earlier about involving the business community, like I don't think scientists thought about why do we need to talk to insurers or healthcare companies or business leaders about this? Because they are the ones who are going to either pay, make it easier to get access to it, or restrict access. And so those conversations are happening. The discussions about how does racism play into this, not just interpersonally about how does somebody treat you based on the color of your skin, but what are the policies that are set up that differentially impact people based on the color of their skin, either giving them privilege or restricting access. That's happening around HIV, and that was not happening 20 years ago or 10 years ago. I think if we get serious about looking at all these levels and have an integrated strategy to address all the levels, to me, it is the most remarkable thing that's happening right now, and I think it has promise.
Well, in December, when Dr. Fauci was leaving NIH, he sat down with me at Queer News Tonight, and we discussed extensively the history of his involvement in HIV, and he left me with kind of a chilling conclusion of his retirement from NIH in saying that the goal of where we should be in 2030, we are significantly lagging behind the goal. And he gave an ominous warning that unless we're serious about it, we can't accomplish it. And the actions prove our seriousness. It's one of the reasons why we're thrilled to talk to you today. We participated in broadcasting Men's Wellness Conference with Florida Department of Health. This is a very, very important topic to honor all of those that we have lost to AIDS. This conversation honors them to say it's front and center for us. We're giving the website lots of information available at hptn096.org. Make sure that you check that out. And Ederick Johnson and Dr. LaRon Nelson, we're very excited about your addition here in South Florida to this Yale project, and HIV really critically important for us. As I said at the top of the introduction of you, HIV/AIDS is probably socially for our community, our LGBTQ community, certainly gay men, probably the most important topic in the history of our lives. And so it's something that we've got to keep front and center. And I thank you very much for being with us tonight at Queer News Tonight.
Thank you. Thank you.